Wonderful. We are now recording. Welcome to Quality Leader Session, and we're very pleased to have Natasha Brown with us speaking on disaster management and emergency preparedness. Really important topics for all of us, and really has the ability for us to transition this from being just a task that we need to complete into a strong operational strategy for real success that we have. So without further ado, thank you so much, Natasha, for joining us. We are very excited to host this session and learn more about this really important topic.
Thank you. Thank you so much, Alyssa, for the warm introduction. I can focus better once I make sure that we are on and you can see my screen.
We can.
Okay, let's try this again from the beginning because this is where it froze on us. So are we good to go?
We're good.
Okay, perfect. All right. Well, thank you so much, Alyssa, and good morning to all of the participants. And Alyssa, I am honored that you reached out to me to do this. I kind of, when you said, I was like, oh my God, I get to go back and do what I've loved for so many years. Although I think I have officially retired from healthcare. So a little bit about me. I've been a healthcare executive for I have 24 years of long-term care experience. It was my very first job out of college. And I remember asking my supervisor, why did you hire me? I have no experience. And she said, well, you seem eager to learn. And I was like, okay. And I remember having to do an MDS assessment and then do a note in the chart, and the nurses pulled me aside and they said, first of all, you don't write in this type of ink. If water was to spill on the chart, it's going to get all over everything. You don't say I went, you speak in third person. I said, well, nobody never told me. I didn't learn this. I worked with juvenile delinquents in college. This is the only job who would hire me. So that was my experience. And for there, I quickly became director of social services, and that was my love for so long, and then continued to take different positions as director of social services, went into hospice marketing. And then I went to work for the state of Georgia for about 5 years as the vulnerable populations coordinator. And so I did not know what that role was going to entail, but I ended up starting the first vulnerable populations program for all of the nursing homes. And so that's where emergency preparedness in Georgia really took priority due to that partnership with Georgia Healthcare Association, and then having the opportunity to touch all 300 plus nursing homes in the state of Georgia and develop plans for them. And then I went on to Pruitt Health to serve as the emergency compliance specialist and the vice president of policy management. And so that's what I've done for the past 9 years up until November, when I think like I said, I retired. But I still have my first love is long-term care, and emergency preparedness is very fun to me. And it was, again, nothing that I wanted to do. That is not why I thought I was accepting the role with the state of Georgia. And they were saying, you have to do exercise. And I was like, do I have to go to boot camp? Am I going to have to be physically fit to do this job? No one told me that. And they say, no, you're going to sit at a table and you're going to do role plays. I said, oh, well, you should have said that at the beginning, because I was about to quit, not even resign. I was going to quit because I'm not doing that. So that's what I thought training and exercise was. And I was like, we're in the military. We're like, what are we doing here? So that's what happened with that. And so it is my first love because I had to learn it. And even to make emergency preparedness that training more accessible, there was a grant that I was able to award the Georgia Healthcare Association with, so that they can employ a full-time emergency preparedness person there that could be just readily accessible and available to their members. And so here we are. I think that making it so important as a result of Hurricane Katrina, that's how I developed my love for it, and then trying to find not easy, but make the education more attractive for nursing homes, because I do realize that as leaders or director of nurses, social services, all the roles, emergency preparedness is not a priority until it is a priority. And that is when the real emergency or emergency event strikes. And what we want you to do is that if you are prepared, then you can respond more easily and quickly, but also to understand that it's not a one-time thing. And we'll talk a little bit more about it. And so we're going to just dive right in here, and so that I can get into the meat of it and honor the time. Every nursing home, well, let me back up a second. You're going to hear me respond to it as emergency. You will rarely ever hear me say disaster, because every emergency does not have to end in a disaster. The building is not catching fire and burning down. Residents are relocated and never coming back to the building. So all emergencies does not have to be disastrous. It is just an emergency event that you're having to respond and recover from. So you'll rarely ever hear me say a disaster. It is an emergency event of any sort, whether it's small, medium, or large. It's an emergency event that has caused some type of disruption in your normal operations for the center. And so every center, and I know you know this, should have an overarching emergency operations plan that outlines these components. So, and follow me clearly, there's procedures, but you also have to have that one plan. It's whether it's a 2-page document, three-page document, is most certainly should be more than 1 page, but spells out the who, what, when, where, why, and how. It is our policy. It is the policy of CCME or what have you, to provide training, education on an ongoing basis so that our residents, staff, family members, and community partners will know how to respond and know what our plan is for responding to emergency events. It's your bold statement of why we do what we do, who we do it for. What? Now that is what is your policy on it? So it is, this is how we're going to respond, when, how often. So it is, okay, Natasha, if a surveyor is to come in, let me see what your plan is or what's your policy on emergency operations. That is where this comes in. And it will tell a surveyor, it'll tell anybody. It says when we're going to, it is CCME or what have you, I'm just for the sake of training. We will provide training and education on our emergency operations plan quarterly, annually, as needed in response. So it should state that. So every staff member or any new employee that's coming and reads your plan, they'll know, okay, I'm going to get training on this plan this often, that often, what have you. So it's there. It also tells where the plan is housed. The plan, the emergency operations plan, is housed in the administrator's office, front desk, every nurse's station, maintenance director's office. So it tells you where it's located. It tells you why we train. We train on our plan because we have identified these emergency events as threats to our center. So therefore, we have to plan and train on how we're going to respond to what these threats are. And we're going to get into that in the next few slides. And how. How will you notify family? How will you notify staff? How will you notify the corporate offices? It spells out. Should an emergency event arise at our facility, we will notify our families by use of our Everbridge system, by use of email, by use of text, by the director of social services will contact every family member by phone within, a certain amount of time as soon as it presents itself. So it kind of spells out how you're going to notify your families. And so therefore, on that mission, family night or what have you, it's already spelled out, and you can let your families know that should an emergency event strike at our building, it is our policy, because it's written in your emergency operations plan policy, that we're going to notify you by use of text message. So if you've identified that you're going to notify family members by text message, then that tells you what? We need family member cell phone. There's nothing worse than you're trying to notify them by text, but it's going to their work number because that's all you have on the chart. So it's important that most people don't have home phones these days. I'm surprised when some of my friends do. And I was like, why are you doing this? So, but we have to think about our population, right? They're older, and so some of their family members could be older. It could be an older husband that's in the center, and the wife still has a home phone, may not know how to use it. So you have to know each and every one of your family members' preferred method of communication. So you'll know, all right, these are our phone calls, these are our text messages. We can send all of these a message by the Everbridge notification system, what have you, but you have to have redundant methods of communication. So therefore, one plan that spells out who, what, when, where, why, and how, and you train. This is your governing body, whatever, this one document. So my slides kind of got out of place here. So we're going to make sure that your objective today is I'm going to educate you on your entire emergency, the whole emergency operations plan process. So now let's move on. And this can very well be interactive. So Alyssa, I'm fine if anybody wants to stop me to ask a question. I like that better anyway. So I know you've heard of this before. This is not new, the 4 phases, but I like to talk about them a little bit differently. And we know the 4 phases, and I hope we all know: mitigation, preparedness, response, recovery. But you have to mitigate because you need to assess what the threats are. There's nothing that I didn't preach more of. How are you training on your emergency plan or disaster plan? Because that's what a lot of the state officials and CMS calls it. But how are you training on your emergency/disaster plan if you don't know what your threats are? There's no need for you to be in Florida, but you're planning training on snowstorms. It doesn't fit. It's not a threat unless there's something that I don't know. There's no need to plan for hurricanes in your area if it happens, but it's not one of those events that will threaten our building. Let's see. So it's those different types of things, and everyone, and I said this for years ago, that every center should have gone back and included pandemic as a threat in their emergency plan, because we were not prepared. We got caught. So pandemic should be should be a risk for everyone, every single healthcare center. Then you have to prepare. You can't prepare with training and education until you identify what your threats are. And we're going to talk about how to do that. So you train and educate based on the threats to your particular center, not what happens at Christine, Denine's, or Autumn Center, but what will happen at your particular center. And then look, something's bound to happen. It's either something that you've been training for or something that we did not think would happen, i.e. COVID. So you have to train. I mean, you have to then, I think I just froze again. Did I freeze, Alyssa?
Yes. But your sound is still coming out well.
Okay, and do you see my cursor?
I sure do.
Okay, I'm gonna stop my video and see if that will help. Uh-oh. Can you hear me still?
Yes, ma'am.
Okay. So then you go into the response and then the recovery. And so with the recovery, that's your opportunity to assess what went well, what your gaps in the plan are, and what your opportunities for improvement are. And we're going to talk about that a little bit more too. But after you respond, most people respond to the emergency and they just try to get back to normal. But you miss that opportunity to do that where you have, okay, let's kind of pull out our form and let's assess, okay, first of all, we need to document what happened in our plan. It's called your after action report, AAR, after action report. And in that after action report, okay, we're doing a synopsis of what happened at our building, but outside of the synopsis, we're going to say you're going to bring your team back together and assess what went well, what were our gaps, and what are our opportunities for improvement. Still with me, Alyssa?
Mm-hmm. Yes.
Okay, 1 second. My screen is not advancing. I don't know what it is with me in Zoom. I have no idea. But I am going to oh goodness. and I'm afraid it's asking me to close the program. And I'm hoping that that does not take place. So I am so, so sorry about this.
Natasha, do you want to send me the slides and then I can just in case it doesn't come back up, I can run them for you?
Yes, I'm going to do that right now.
Okay, while you do that,
Can you pause and then pick back up on your recording?
yes, ma'am, I think.
They have, you know, so when was your last emergency preparedness training on? When was your last fire drill? You should not have to scramble for anything. And I would like to kind of pat myself on the back, but that's something that I had for all of our centers. When I worked for Pruitt Health, it was a notebook. So no one had to go and try to go to the nurse's station, the administrator's office in case the administrator's on the beach in Cabo, the maintenance director is gone. It should be in that one book. And you can flip that tab to training. And so once you just do a Word document and just print out all these sheets and stick it in there, all you have to do is write up what we trained about, the date, the time, and who was present. And that's it. And then therefore it's easy for you all to go back and reflect on it, or it's easily accessible. Then when a surveyor or someone comes in, they want to know what's your policy. Go to the book. This is our policy on it. Someone asks, okay, well, what are your procedures for evacuation? Oh, well, let me show you my evacuation procedure. Step 1, we do this. Step 2, we do that. Step 3, we do that. So in each and I don't want to move ahead, but that is what I suggest every center has, and that's one emergency operations notebook. And so I'm going to jump back into the presentation. And the question I have, because we went through before my computer failed me, we were talking about the 4 stages of emergencies, and that was mitigation, preparedness, response, and recovery. And now the question is, what do most centers forget to do after recovery? And you can hit next, Alyssa. And that's mitigate. You forget to go back to mitigation. You figured, okay, we've come through this, we're good now, let's get back to business as normal, and it's not. We now have to go back to the mitigation portion again. So it doesn't stop after, okay, we had a hurricane here, we're back in our building, we're trying to get things back to normal. All right, let's just breathe a little bit. No, you've got to now mitigate. And what does that look like? Developing your after action report. You should have a standard form where, again, you're able to write down the event that happened, when it transpired, who was involved, what you did to respond, where did you evacuate to? Because sometimes, like the state may want those things. Then you have to ask yourself, what did we do well? What didn't go so well? What are our opportunities? Well, third shift didn't know. Well, we didn't have anybody to ride on the van with our residents. We forgot to call the families to give them an option. Some families may have wanted to come and pick up their loved ones, and we didn't contact them. So you have to talk about these things so that therefore you can go back and look at what your actual response procedures are and see if they're realistic, because we can put everything down on paper, but we don't know if what we put down on paper is realistic until we have to use it. And so that's why after you use it, we go back and say, why did we say we were going to be making all type of sandwich chips and all of that for them to go when we only had a chance to give them some chips and cookies? Not that, like, sometimes, we want to be overzealous, and then when it's time, it doesn't work. So you have to go back to mitigate after that, not even after the actual event, but after the exercise, because you should be exercising your plan. Next slide, please. So let's talk about who's on your team. You have to have an emergency operations or emergency preparedness committee. That is essential. What does that look like? That's your center leadership. Everyone who is in a leadership role, the department heads from every department should be a part of your emergency preparedness committee. And therefore, I know most, every healthcare center has stand-up meetings. All right, there you go. After you've talked about census, admissions for the day, all of that good stuff, what matters, our Part A's, you know, marketing, who's coming in. After you've done all of that conversation, all right, let's have a 30-minute emergency preparedness committee meeting. It's right there. You have them. All you have to do is set the date. Every quarter on the third Wednesday of the month, that's emergency preparedness committee meeting day. We're going to talk 30 minutes about it. So you don't have to convene another meeting. Everything is there. You establish roles and responsibilities. If I have administrators on here, don't shoot me. But the administrator leads the emergency operations committee or your emergency preparedness committee, because you have that authority of what happens, how it happens, when it happens, who gets to use the card to go pick up some other things in the emergency. Like, you have the authority in conjunction with the maintenance director, in conjunction with the DHS, or the nurse manager, what have you, in the dietary person. So, but you lead that, you're responsible for it. You meet quarterly or as needed. Everyone on that committee should have working knowledge of what that plan is. Everyone on the committee is responsible for training, because most of those department heads lead other people in that perspective role. So if you're the director of health services, or you're the director of nursing, whatever the title may be, you have charge nurses. So it's like a top-down approach: administrator to department leads to those who are second in authority, down to those who to the CNAs or what have you, from the dietary manager to the cooks to this. So everybody has someone under them some kind of way. And so you're responsible too of making sure they not only know what the plan is for the entire center, but you know what the plan is for your department. So that's why it's nothing. You ever go into Target and you wonder, like, why is everybody in these red shirts huddled up? You know, because they're in a huddle. They're having a quick meeting. There's no reason why, you know, that can't happen in your department. All right. Lunch starts in about 30 minutes before we start serving. Let's have a 10-minute huddle. This is what we've got to do. This is what we need to go in and assess our emergency food and supplies. Make sure that there's nothing expired in there. You know, let's see what we need to do. Let's make sure everybody knows my new cell phone number. Let's make sure you know if I'm not here, what to do, because emergencies don't happen during the day. They happen when you're at home sleeping or out the country. And so that's why everybody needs to know what should take place in the event the key person is no longer there. And so the committee is also responsible for conducting that annual hazard vulnerability assessment. And this is what I'm going to delve into. Next slide, Alyssa. This assessment is absolutely key. I always say, again, I talked about this earlier, are you able to have training and education without an HVA? The HVA drives your emergency operations plan or your disaster plan. It drives it. And it's the process for you to identify what the healthcare center's highest vulnerabilities and threats are, to whether it's a natural or man-made event on your center. So, and it goes like, there's HVA assessments out there. They're all pretty much the same. But what you do is, all right, this is what we're doing for our emergency preparedness committee meeting for this quarter. So we're going to pull out our HVA, or you're going to have to develop one. And, you know, this was one of the requirements from CMS that started a couple of years ago. They were looking for the HVAs. And so that's why everybody needs to have one, and it has to be done annually and or as needed if something changed that you didn't identify for your center, but it happened. So we talk about, all right, what are our top risks to our center based on where we are located? So are we located near a body of water? So that's a risk to us. Are we in a hurricane zone? So we know if a hurricane was to come, that our zone would probably be the ones that have to be evacuated. Pandemic should always be one. Are we prone for fire because of, you know, everybody's fire prone, what have you, but just looking at what the hazards may be. Then you have to think about, now, what is the level of impact on this hazard to our center? And you assess that maybe like a 1, 2, or 3. 1 being the least, 3 being the highest, for example. So you assess the level of risk to us. Then you ask yourself, how prepared are we to respond? So, and you have to be realistic about it. So right now, today, if a hurricane or a tornado was to come and whip through our center, do we feel that our center is prepared to respond from that? And it's the nurse answering that, supply answering that, the administrator answering that, like therapy answering, everybody's answering that question, how prepared are we to respond? Then you give yourself a 1, 2, or 3. 3 being 1, we're not prepared at all. 3, we're very prepared, or what have you. And from that, you multiply the hazards times the risk times preparedness. And then once you take your top numbers, and once you get your top, those highest ranking numbers, those are your threats. That's what you should have emergency response procedures for in training and education. So if someone was to look at your HVA, they should see your response procedures following that. Then in another section in your binder, they should see that you have training that mirrors and that's aligned with what you've identified in your HVA. That's how it goes. That's how it's very simple. So we don't have to think about, oh, what are we going to train on this month? Well, let's look at our HVA. It says that we're at risk right here. So we need to start talking about these things. And ask yourself, if this was to happen at 1 o'clock in the morning, do we know what to do? And who do we know? And who are we to call? So next slide, please. So I just spoke about your response procedures, because your response procedure should be in a section by itself. So if something were to happen on third shift, and because you know that the night shift, they tend to get left behind with all the training, all the fun stuff, unless they take time off or use their off time to come in and get some education or participate in things in the center, because a lot of things happen during the day, but most times things will happen on their shift sometimes. And so therefore, they need to be able to have a place to go to, not trying to unlock the administrator's office, not trying to get into the DON or DHS's office, but they need to be able to go to a binder and say, all right, we have a power outage or it's flooding. We have all of this. Let me go to this book, open it up, and it tells me everything to do from step 1, 2, 3, 4, 5, 6. It guides them through every single step of what to do, so they can't say, well, I didn't know. Well, that means you didn't open the book. It shouldn't be anything kept on the computer, because what if the power fails? So I'm a firm believer that no policies and procedures should be printed out, because it's a moving target, can change all the time. Because we know times change in healthcare. So it should be emergency preparedness procedures should be the only thing printed out in the center. And so maybe make it color coded so they can say, we have a code red in the building. So if it's something happening during the day, you don't alarm the visitors, but you can say, we have a code blue, we have a code red, we have a code yellow. And staff begins to learn what those codes are, because it's right there and it's color tabbed in the book, and they can easily identify the procedures for each thing. And they can reference it, and then you exercise those procedures as need be. Next slide, please. So we talked about the training and education, and the training and education should occur when your plan is reviewed, if you need to revise it quarterly, annually in preparation of an event, after an event, new staff as necessary, and it should be recorded. So that's just a simple form, like I said earlier, when we trained, what we trained on, and who participated. And so, but in your book, you should also keep inside of there your evacuation and receiving centers, a call tree, everybody's phone number. Because again, most leaders only have other leaders' numbers, but no leaders are there late hours most times, maybe a charge nurse. So therefore it should be a list so that the staff would know who to call in the event that leadership is not there. And it needs to be updated frequently as staff changes, phone numbers change. A list of vendors, especially your transportation, your vulnerable residents, who are they? Because if I'm working over on unit 3, I may not know who's on unit 1. I don't know, but just listen, like, who's vulnerable, who needs to get out of here first. Family notification. What is our process for notifying our family members? What does staffing look like during the duration of an event? Because that is when, we try to figure out, all right, we may have to evacuate, or we may have to shelter in place. Who's going to be there? Do we have cots? Do we have snacks? Do we have blankets? Do we have things identified? What if our staff member, we need this key person here, but what if they have to bring their daughter or son with them to stay at the center, because that's the only way they're that's the only way that they're able to stay. And then what does our emergency food and water look like for our center? So I've kind of given you a very deep dive, robust, I guess, hopefully another perspective on how you can view emergency planning, emergency preparedness. Like I said before, I don't like to look at it as disaster, because every emergency is not a disaster, but just another perspective on how you should go about reviewing, training, developing, all of that when it comes to your actual plan, and things that may not have been considered, or you've thought about and now you have another way to look at it. And so, Alyssa, next slide, and I'm going to pause here for questions.
Wonderful. Thank you so much, Natasha. So definitely want to encourage anybody, if you're online, you want to unmute yourself and ask me questions, or you can type them in the chat box. Either way, let's have some good conversation around this. Looks like Chris has a question that she typed in on if there is a plan to restart after an event, like a code black, evacuation, etc. Is there an action plan on how to restart the operations?
How to restart the operations after. I think I missed part of the question. I'm sorry.
Okay, so I worked with a center that had a fire after on restart of all their electrical equipment after a hurricane. And what happened was that their gases were turned on, and the gases were running. And when they cranked stuff back up, oh, there was a spark. And so they had a fire. And so that goes to, where do you have you considered the steps that have to occur in order for a center to be reopened and return to operations after there's been some sort of event? And where would that kind of thing be located?
So in your emergency plan, there should be, when there's an evacuation, then there's a plan or process to shut the center down. And that is, because before that, and I didn't touch on that, but before that, it should talk about where all of your emergency shutoffs are, all of those things to shut the center down. And that's typically done in conjunction with your maintenance director, whether your corporate officials, your community, your emergency manager, people of that nature, to come to help you shut your center down. And the same way you shut it down, then you take that same process to restart it. Because when the center's evacuated, prior to everybody going back in, that's when your leadership should go, let's do a walkthrough, let's do an assessment with our fire marshal, all of those individuals, and let's walk through and look at, restarting, getting our center back up to par, lights, assessing damage, all of that. And so I think that's when that really and truly should take place, because, and I don't know if I missed this, but it never should be, we just move back in. The same, once everybody moves out, someone has to stay behind with the fire marshal or someone from there and start to shut the center down. And that's documented. and then board it up, all of those things, security, even hiring some type of security company to monitor the center while it's shut down. So those are some things that have transpired in the past, but you take that same process and go back to assess, restart, get it up and going, because you'll have staff that should be with the resident somewhere else, but then you have staffing that's there restarting that center. And so that's the only advice that I have there.
Thank you. I just felt like that was something that, you know, people needed to think about, how you resume operations, because if it's done in a haphazard manner, there can be negative consequences.
Absolutely. Great. Also.
Yeah, what a wonderful conversation. I can see, Natasha, from how it's linking, you know, you're talking about coordinating with the fire marshal and the state, and how important that is from lessons that we learned from Hurricane Katrina, so that we also know who else is available to help in those cases, or to hold patients, what that may be looking like from an emergency support system in our area. So that's a really interesting link back into how that all works.
Absolutely. Thank you.
Wonderful. Anybody else have any questions or comments? If you're watching the archive and you have any questions or comments, feel free to let us know. We will get those answers back to you, and we're happy to dig into them and connect back with Natasha and her amazing level of expertise that she has.
Thank you. And that's all what's on the next slide. It's how you can contact me. And I like I said, I totally enjoyed this just as much as I enjoy policy management and helping centers really, just take their policies and allowing their policies to work for them, and as well as emergency preparedness, and not making it such a huge task, but just making it a part of what you're already doing. So thank you so much for the opportunity, and I look forward to continuing to partner with you.
Wonderful. Thanks so much, Natasha. Thank you everyone for joining, and we are happy to support you. Don't forget, we're coming back in 2 weeks with another wonderful session. I believe it is our session on from CCME. Our team here internally is going to be presenting on sepsis and sepsis work. It's a big area of opportunity for us. Coming out of the pandemic, we're getting back to the basics on things, and there's some great opportunities in really being able to look at our programming for sepsis and prevent those unnecessary hospital transfers, and be able to support better outcomes for our patients. So hope to see you back here in 2 weeks. Otherwise, have a fantastic weekend and a wonderful 4th of July. We'll see you in a bit. Goodbye, everybody.